Sepsis remains one of the most serious conditions encountered in hospitals, contributing significantly to morbidity, mortality, and overall healthcare resource use. The primary challenge is identifying it early, because the first clinical signs are often subtle and easily overlooked in busy environments. As healthcare systems collect increasing amounts of electronic data, artificial intelligence models, such as machine learning and large language models, are being explored as tools to detect early patterns associated with sepsis. In this presentation, I will summarize 6 recent studies evaluating AI-based sepsis detection systems and discuss their performance, limitations, and potential implications for clinical practice. Early sepsis often presents with vague symptoms such as mild fever, slight tachycardia, or subtle changes in mental status. These signs overlap with many other conditions, which makes early recognition challenging. Delays in identifying sepsis are strongly associated with increased mortality and higher ICU utilization. Nurses frequently detect early changes, but this happens while managing multiple patients and competing priorities. AI systems may help by continuously analyzing large amounts of patient data and identifying patient patterns or trends that suggest early deterioration. The purpose of this review is to examine how artificial intelligence is being used to support early sepsis detection and to evaluate how effective these models are in practice. I focus on each model's strengths, limitations, data requirements, and whether they appear feasible for real-world clinical use. A second goal was to identify broader themes, such as generalizability and equity concerns, to assess how close these tools are to being ready for routine implementation. Across the studies, most AI models demonstrated strong performance, with ROC values between 0.80 and 0.95. ROC is a measure of how well a model distinguishes between patients who will develop sepsis and those who will not. Values closer to 1.0 indicate stronger accuracy. Several systems were able to detect sepsis risk hours before clinicians recognized it, sometimes providing a 3 to 12 hour early warning window. Models that combine multiple data sources, such as vital signs and information extracted from clinical notes, showed the best improvements in precision and the largest reductions in false alarms. Performance was strongest in ICU settings, where continuous monitoring provides rich data for analysis. Different AI systems depend on different types of data, which affects where they can be used effectively. ICU-based models rely on constant monitoring and frequent lab testing, which supports high accuracy, but limits use to resource-rich environments. CBC-based models require only routine laboratory values. This makes them highly accessible, especially for emergency departments and hospitals with limited digital infrastructure. Models that incorporate large language processing rely heavily on timely, detailed documentation. If documentation is incomplete or delayed, their performance may be reduced. Because of these differences, there is no single AI model that works best in every setting. The optimal approach depends on clinical environment and available data. A major challenge in sepsis screening is the high rate of false alarms from tools like SIRS and NEWS. These can overwhelm staff and contribute to alarm fatigue. Several AI models significantly reduce false alarms, at times lowering them to single-digit percentages while maintaining good sensitivity. Hybrid systems that selectively use a language model achieve the highest precision, meaning a larger portion of alerts reflected true clinical concern. Importantly, these alerts only help if they are integrated directly into nurse workflows. For example, through EHR notifications that appear where clinicians already chart. Generalizability, equity, and model quality. Many AI models were developed and tested in a single academic center, which raises questions about how well they perform in different hospitals or patient populations. Studies also use different definitions of sepsis onset and different prediction timelines, making results difficult to compare. Studies also use different definitions of sepsis onset and different prediction timelines, making results difficult to compare. External validation, testing the model on entirely new patient data, was uncommon across the literature. The most concerning gap is the lack of equity analysis. Very few studies reported performance by race, ethnicity, gender, or other socio-demographic groups, and none used formal fairness metrics. Without this, we cannot determine whether these tools perform consistently across diverse patient populations, which poses a risk of unintentional bias. When synthesizing all 6 studies, each model type offers distinct advantages. ICU-based models achieve high accuracy and meaningful early warning capability, but require advanced monitoring systems. CBC-based models are simple and widely accessible, but have been tested mainly in narrower patient groups. Hybrid models that incorporate language processing show the strongest precision and lowest false alarm rates, but they depend heavily on documentation quality and technical integration. Overall, AI-based sepsis detection is promising, but the field lacks standardization in definitions, reporting, and validation. For nursing practice, AI systems have the potential to support earlier recognition of patient deterioration and improve accuracy of alerts. However, these models are not ready for automatic deployment. Nurses will need education on interpreting AI-generated scores and understanding their limitations. Until issues such as standardization, validation, and equity testing are addressed, AI should be considered a decision support tool, not a replacement for clinical judgment or bedside assessment. Thank you.